Department of Prosthodontist and Scientific Committee, take immense pleasure to welcome our respected Dean Sir, Dr. Anand Shegli, and our guest speaker of the day, Dr. Sumedha Dandekar ma'am, and all the respected HODs, staff members, and students who have gathered here for celebrating World Prosthodontist Day.
I, Dr. Sumedha, Senior Lecturer, take this opportunity to call upon stage our beloved HOD ma'am, Dr. Kamal Shigli, Professor and HOD, Department of Prosthodontics, to brief us about this special day, that is World Prosthodontist Day.
A very good afternoon to one and all. I, on behalf of the Department of Prosthodontics and the Scientific Committee, DYPDS, take this opportunity to welcome our guest speaker for the day, Dr. Sumedha, our staff members, and my dear students. So we all have gathered here for the celebration of Prosthodontist Day. The celebration of this day is an initiative by the Indian Prosthodontic Society and the Asian Academy of Prosthodontics to create an awareness among the colleagues and also among the public regarding this specialty. On this occasion, the Indian Prosthodontic Society, Pune branch, sponsored us with teeth sets and denture-based material. And I'm very happy to say that our final year students who were posted in the Department of Prosthodontics made the best use of it. Under the able guidance of our staff members, they will be inserting complete dentures. Also, on this day, we have with us our guest speaker for the day, Dr. Sumedha Dandekar, who is a dental sleep specialist and a prosthodontist who is associated with Dinanath Mangeshkar Hospital. So she will be enlightening us about dental sleep medicine, a dentist perspective. So with these few words, I welcome one and all. And I also like to end my note by saying that we all are prosthodontists and we are very proud to be a prosthodontist because it is God who creates, but it is we who recreate. So thank you once.
Thank you, ma'am, for the wonderful briefing. Now I request Dr. Paulvi Bakchi, Professor, Department of Prosthodontics, to introduce our guest speaker to all of us.
It gives me immense pleasure to be standing here in front of all of you and introduce our guest speaker, Dr. Sumedha Dandekar. She completed her BDS from BBB Pune in the year 2005. Subsequently, MBS in Prosthodontics in the year 2010 from DY Patil, Pimpri. She is also a dental sleep medicine specialist from Florida, USA 2016 and also completed 1 year of residency in Boston 2017. She completed her certificate course in geriatrics and gerodontology under Geriatric Society of India in the year 2020. Amongst her social work, it includes that she is a member of the National Service Scheme India, performing dental checkups and providing dental awareness, which benefits the socio-economic backward classes. Dr. Sumedha Dandekar is currently working in a specialized clinic as a prosthodontist in Pune and is also a dental sleep specialist. She is an honorary consultant prosthodontist and dental sleep specialist at Dinanath Mangeshkar Hospital and Research Center, Pune. The geriatric course she completed in 2020 tied together her passion not just for prostho but also for dental sleep medicine. She has successfully cleared the Diplomat Part Board Certification exam in Indian Board of Prosthodontics and is a fellow in the Indian Society of Oral Implantologists. She is also a fellow of Indian Congress of Oral Implantologists and her research interests include single anterior implant aesthetics, augmentation materials, sleep medicine, TMD, TMJ, so on and so forth. She has been extensively involved in creating awareness on sleep apnea, which is our topic for the day, and of course its related disorders. She has interestingly started an online blog in creating social awareness, which has got a lot of popularity in the recent past. She has been invited to speak on topics ranging from sleep medicine to TMJs to TMDs in various Rotary meetings, institutions and national podiums. And apart from academics, I would like to end by saying she is an avid runner, a fitness enthusiast and strives to instill these values in her 2 children and her very loving husband. So with that, I will come to an end in introducing our speaker of the day. Thank you, ma'am.
Thank you, ma'am, for a wonderful introduction of our guest speaker. Now I kindly request our respected Kamal Shigli ma'am to welcome and felicitate our guest speaker for the day, Dr. Sumedha Dandekar.
Thank you so much, ma'am. It's indeed my immense privilege to call Dr. Sumedha Dandekar, ma'am, to take over the dais, as we all are eager to know and learn about the lesser known aspects of this topic.
Can you all hear me? Am I audible enough? Perfect. So thank you so much for giving me the opportunity, Kamal ma'am, so that I can come here. I love speaking to students. So Anagha madam over here has been my batchmate. We were undergrad batchmates at Bharati Vidyapeeth. So she knows me for a very long time. And we were not very good students, let me start with that. We were sincere, mind you. But we had a hard time coping up with a few topics, but I will not disclose those topics right now. But apart from that, in my mind I knew that it's very, very tough to try to reach students because we've been students ourselves. And it's to get into the mind of the student and try and make the topic interesting is a very big deal. So I really commend the entire staff department over here. I think teaching is a very honorable profession. And in spite of me trying, I don't think so I'm a very good teacher, but I try to speak. So my idea and my goal over here is to try to create awareness. And if you ever have any doubts, if you need to reach out, Kamal ma'am, Anagha ma'am, all of them have my contact details. So do try to reach out on a one-on-one basis. Maybe I can be of some help to you. So let's start with the topic. Sleep medicine is a very different, new, out-of-the-box kind of topic for all of you. It's not exactly a very new topic if you consider a global aspect, because dental sleep medicine is picking up on a very large scale all over. We in India have not been exposed to the various aspects of it, so that is why I think it's very new for us. But the problem exists, there is a huge problem, and treatment is at hand. So today, by the end of the lecture, I hope you will all be a little more adept at recognizing the problems and understanding what kind of treatment can be done. This is what we've already spoken about. Just take a note of my email address. So in case you have any queries, you can get in touch with me. So this is what all of us come across. So many of us who are married and many of us who will be married soon, we come across circumstances in which you actually want to try and get the gun out. Because if you can't sleep or the husband is not letting you sleep, Or it could also be vice versa. I'm not being feminist, but it could also be the woman who is snoring and the husband may not be able to sleep with it. So we want to try and avoid this kind of problem, and hopefully help is at hand. So when we talk about sleep, we need to understand that what is it that we need to know about sleep. Why is it important? How can we get better at sleep? And what is it if I don't get enough sleep? What are the exact number of hours that are required in sleep? So sleep is a very huge and a very grey area. It's murky topic, and there is a lot of, opinion about the topic, because everyone says that I am okay with only 2 hours of sleep, and someone says that 8 to 10 hours of sleep is what is important. So it's a very personal topic, and there are some papers which say that what is important and what is not. But according to me, it's what goes well with you. If you can function efficiently, I think that amount of sleep is okay for you. I will come in detail to all of these topics. I'm just giving you an overview of what we will be speaking. So in short, what are we going to speak about? So what does sleep exactly do to you? It helps your brain recharge. You need a mental and bodily rest when you go to sleep. All your cells are tired, and along with your cells, your brain cells are also tired. So there is a physical component and a mental component. So sleep is important so that you can recuperate on both these aspects. Also, they help your cells to repair themselves. So it helps your body building mechanism, and it also helps release some important hormones. So why exactly do we need sleep? What exactly does happen when we sleep? The first one is very important because all of us are in the zone of how to get fitter, and that has been one of my other pet passions apart from dentistry, on how to promote fitness also. So it does help maintain weight. How does it do this? There are 2 types of hormones which are there in our body. There is ghrelin and there is leptin. Ghrelin is the hormone that makes us feel hungry, and leptin is the one that makes us feel a little fuller. So there is a balance of those hormones which are maintained in the body. And obviously, the longer amount of time you're going to stay awake, you're going to feel hungry even more. Imagine on those days when you have a holiday, or if you are free and you are around, if you're in the house, automatically you end up opening cupboards, you end up opening your dabbas, you end up feeling hungry. And on a working day, you don't even notice because you're so busy in work. You don't notice if you skipped lunch, you don't notice if you skipped your tea, and you end up working longer. So ideally, we've been born and we've been created as humans to work along with the circadian rhythm. That means you wake up with the sun and you go to bed with the sun. That is what our system works like. But along with, technology, improvement, modern lifestyle, we end up creeping into the night hours more, and you end up falling short on the sleep that's required for the body. That also means you do not make the most of the early morning hours, which according to me are the most productive. I'm an early riser. That does not mean that people who sleep late or the night hours are wrong in any way, but it depends on what kind of person you are. Anyway, the topic is sleep, so we'll come back to sleep. So it does help maintain weight. Apart from that, it helps to improve concentration and productivity. So when you have slept well, remember when we were much younger and our parents, our grandparents used to say that, if you have slept well and if you are sharp enough, you'll be able to perform better. And when we were younger, we didn't, but we have to study the topic. So what happens is when you're sleeping, everything actually comes back to you. So this is not just a joke, it actually does happen. Your brain gets a chance to recuperate. Everything that you've read, even much earlier, there's a chance for you to inculcate it back into whatever you're doing right now. So productivity does increase. It can also maximize athletic performance. There are different studies which show that it can enhance fine motor skills, reaction time, your reflexes work better, so you'll be able to perform in an athletic field in a better and a more stronger position. Also, lack of sleep will also increase the chance of injury. So the chances, if your reflexes go down or if your attention span is diverted, you are likely to get injured more, and that is what is going to cost you in your athletic performance. So if an injury versus better performance, if sleep is the only factor, definitely you need good amount of sleep before your game. It can strengthen your heart. There are some articles which say that if you have a risk of high blood pressure, I will come to this when we talk about other symptoms. So what happens is when you are asleep, your entire body goes into a stage of rest. When I mean a stage of rest, that means your heart rate also reduces, your body mechanisms slow down, and you end up breathing easier. So there is something called the resting heart rate, which is different from the regular awake time heart rate. So your sleeping resting heart rate and your awake time heart rate, there is a big difference. And why does that happen? Because your body needs to function continuously. So when it is functioning continuously, it needs a little lean time. That means it needs a little rest time. But our heart is such an organ which cannot completely shut off, right? So there has to be some amount of low pumping action which is going on. So what happens in sleep is if you have got enough of deep sleep, this low resting heart rate gives your heart another chance to try and start acting in a regular way when you wake up the next day morning. And if you're not sleeping well, if you're having any episodes or any choking sensations, any disorders of sleep, imagine your heart is beating that much more. So the resting heart rate gets elevated, it's pumping over time, so it's doing double duty. When that happens, of course, it's going to lead to fatigue, and that fatigue leads to chances of high blood pressure. So there is, whatever I've written in red was interesting to me. So, but it also kind of, like how we say every story has two sides, so there is a positive and a negative. So it also says that excessive sleep in adults, that is more than 9 hours, was also shown to increase the risk of heart disease. So tomorrow I don't want all of you to go and say to your teachers that, you know, Sumedha said, she said we need to sleep longer. So this is for teachers to take hold of you. There's also a chance you don't need to sleep that much more also. It also affects your sugar metabolism, diabetes 2 type risk increases. There are changes in decreased insulin sensitivity, increased inflammation and hunger hormone changes. This is what we spoke about when the other hormones, ghrelin and leptin. So similarly, and sleep deprivation is associated with a higher risk of developing obesity, because the longer you are awake, you have poor decision making skills and you may end up eating a little bit more. And that itself will lead to a metabolic syndrome disorder. It can cause depression. There are multiple articles which say that you need enough amount of time. Now depression and stress are two very, very new and upcoming babies, I must say. They have been there in our society for a long time. But now every second patient that comes to me, it could be an 18-year-old girl or it could be a 75-year-old man. Everyone says, I'm under too much stress. So every time I ask them, what is it that you feel? What is stress according to you? So for that young girl, you know, she's read it somewhere or she thinks it's cool to say this. Possibly she may be having a little tough time coping with the studies. For the older man, you know, genuinely he may be worried about his daughter, his daughter-in-law, his grandkids. But stress and depression are upcoming ugly heads in our society, but help is at hand, and there are multiple patients who are undergoing antidepressant treatment, and those drugs can also hamper with entire physiology. So make sure whom you are treating. But why am I included it in our sleep topic? Because there are several mood changes and anxiety attacks which can happen if you have not rested well enough. So that is why it says that it can also cause depression. So sometimes if you may not need any separate medication, you just need a good amount of rest and all your depression symptoms may actually go away. It also supports a healthy immune system. Lack of sleep has shown to impair immune function. In one study, the participants who slept fewer than 5 hours were 4.5 times more likely. That's a huge number if you compare statistically to regular cold and cough. So they say that if you have enough rest, your immune system works better. So imagine this is your haldi ka doodh that you are taking. A good night's sleep is equivalent to an immune shot. There's also a funny article which I came across. It says that the COVID-19 vaccine efficacy is also more in sleep. I doubt if this is going to happen, otherwise everyone will take the entire day off, I need to take a vaccine. So I don't know if this works. Poor sleep is also linked to increased inflammation. This is an important point. I want you to understand this very well. So what happens is sleep plays an important role in regulation of our CNS. So everyone knows there's a hypothalamic pituitary adrenal axis. So that is our main axis which controls our systems. Whenever you have sleep loss, especially for disturbed sleep, it is known to activate your inflammatory pathways. What it does is it will lead to higher level of undesirable markers of inflammation, like your C-reactive proteins and your interleukin 6. And over time, when you know that we have higher C-reactive protein or interleukin, your chronic inflammation cases will increase. When that happens, we know that whenever we have a long-term chronic case, there is a likelihood of going into cancerous lesions. So that is why inflammation and trying to control inflammation is a body mechanism, and sleep is going to help you combat that. So in short, this is to summarize. So it actually helps you function better. It makes you smarter. It improves your brain function. It improves your mood. It reduces your depression. It improves your exercise performance, as we spoke about athletic performance. It boosts your immune system. It reduces risk of weight gain. Reduces your risk of heart disease, and reduces risk of type 2 diabetes and inflammation. So now we've understood why do we need sleep. Let's talk about what exactly happens in sleep. So when we talk about sleep, I'm going to divide it into basic 5 stages. First stage is called as a lighter sleep, in which your EEG activity is very similar to what it is like in wake time. So imagine you are awake, and then when you lie down in bed, you're still getting into your sleep zone. That is your first stage of sleep. The second stage is deeper than that, and it shows a sawtooth kind of activity. Those are the spindles which are shown in the EEG. I'll show you some pictures for that. Stage 3 and 4 are called as slow wave sleep, which is going into your deep sleep, and your stage 5 is actually your REM sleep, that means your rapid eye movement sleep, in which maximum deep sleep occurs. Over here, the breathing is a little erratic. So these are the 4 stages of sleep. So stage 1 to stage 4 is considered as non-REM sleep, and your stage 5 is actually your REM sleep. So over here in this picture, you have stage 3. So you can combine stage 3 and 4 together according to the symptoms I told you. So this is what you see in an electrogram activity. So this is the kind of movement of your eyeballs, what is happening when you are sleeping. So when we do any kind of polysomnography, polysomnography is a kind of test that we do when we want to try and understand how you're sleeping. If I have to gauge Kamal ma'am's sleep, she says, I don't think so I'm sleeping well. It is not possible for me to personally sit by her side and watch her when she's sleeping. Maybe possibly I will stay awake and I can actually watch her, but I do not know what is happening to her body when she is sleeping. That means what is happening to her heart rate, what is happening to her functions, what is happening to her changes. Hello. And so how do we try and get hold of this? We have some systems in place. So we have certain markers, you can align it and you can attach those onto Kamal ma'am's body, and that gives us a data. It gives us a graphic representation of what is happening. And that is how we will be able to gauge on what is happening to her in sleep. So those are called as polysomnographies. Polysomnographies can be of 2 types. There can be one which is done at home and one which is done in the hospital. I'll come to that later. Now coming to the topics, you've understood what is sleep, you've understood why you need sleep. What is obstructive sleep apnea? It is basically a breathing disorder in which you have difficulty in breathing. It is an independent risk factor for cardiac, neurologic and perioperative morbidities. This disorder remains undiagnosed in a substantial amount of population. I'm going to come to a few statistics, you will know how large. And it's imperative for all physicians to remain vigilant about the signs and symptoms. So today, after I finish talking about the topic, I want you all to try and understand these patients. You should be able to pick them out from a group of patients sitting in your waiting room, or a group of your friends who are sitting around, or people whom you may meet outside. You should be able to pinpoint and pick out these people and ask them questions, leading questions that, do you sleep well? Do you have morning headaches? Are you grinding at night? You'll be surprised at the amount of answers you will get, and you'll be like, how did you know? It's very easy to try and pick on these patients, and it's always imperative to try and get them to get themselves tested. I'm not saying immediately put them in a chair and kato, but at least find out what is required, get them tested and find out what can be done. So it's a disorder in which a person frequently stops breathing during his or her sleep. So there are small episodes called as apnea. Whenever there is stoppage of breathing, it is called as apnea. When there is partial stoppage of breathing, it is called as hypopnea. It results from obstruction of the upper airway during sleep that occurs because of inadequate motor tone of the tongue and or your airway dilator muscles, which are your inner muscles inside your throat. Now, these are the statistics in the US. So it is estimated to be 3% to 7% in men and 2 to 5% of women overall. So imagine the population of USA, and if you have nearly 5% of all the men who are afflicted with something called as obstructive sleep apnea, imagine what a large pool of patients that you have, that you can treat. Unfortunately, we do not have very great data in India, so the studies are not enough for me to be able to give you Indian statistics, but I think I found a paper in 2010, I'll come to that. The prevalence of OSA can be as high as 78% in morbidly obese patients. So if you are to go to a bariatric care center or a labor obese center, So the amount of people you will find over there, around 78% of them will have a problem of sleep apnea. Why is this important? Because there are very important perioperative complications which can come across over here. Because if your airway is not open, imagine how will you intubate the patient? How will you go ahead and perform your surgeries? So it's important to diagnose, to at least kind of understand where it is going or partially treat the case before the patient goes in for any kind of bariatric surgery. So up to 93% of women and 82% of men have undiagnosed moderate to severe OSC. That is why it's important for us to know and understand these patients and try and get them to the forefront. So this is that Indian study which I told you about. It's a 2010 study in which I would say there's 100 million approximate cases. 7.5% of the population has sleep apnea. Around 34 million, that is 3.42%, and 82% of patients remain undiagnosed out of these. So imagine there is such a large amount of population, and this is from 2015. There's nothing which is even latest which I could find. If you consider the total population of India, 1.3, out of 50% of which is below the age of 25, and all of these studies were done above 25. So imagine below 25, this is untapped data. So you being in college, it's going to be a great opportunity if you can kind of have a drive or kind of, do kind of basic testing, at least to get some kind of a review or some kind of statistics, so that we will be able to compile some data and find out what happens. Because as a single practitioner, it's very difficult to get any kind of data. I will have 10 patients, you will have 100 patients in the same amount of time. So if everyone combines together and have a basic questionnaire, I think it will great help to general sleep society in India, because it will give us data. So this is the kind of incidence of OSA when we consider mild, moderate and severe. The red is showing severe and the green is showing mild. So why have I divided into three parts? If you are in the mild to moderate range, there is a high probability that you will have a chance of dealing with it better with a dental device only. When you are in the moderate to severe category or the severe category, there is a likelihood that you may need something more invasive. That means you may need different contraptions for you to help yourself to breathe better. This is also important because imagine, now this is again a US based study, imagine if you can correlate it to an Indian population, I think we'll be very close by. Imagine the amount of economic deficit a country has to bear because of improper sleep. So there are those many number of accidents which are taking place. So that's the cost of $6.5 billion. If a person has not slept well, he will not be able to operate heavy machinery. If he can't do that, he will be making mistakes. There will be people who are actually dying, or there is a lack in economy because there is not enough productivity in that sector. Apart from that, there are motor vehicle accidents. If the dry goods have to reach a particular place, if the person has not slept enough, he will never be able to reach, and also he is causing that much deficit because he is getting insurance out of the country's packet, right? So this is a huge problem all over. And also overall there is a loss of productivity. Imagine with those accidents and those motor vehicle accidents, you basically were functioning at 100%. Now suddenly your working potential goes down to 60%. That is the amount of efficiency lost, that much amount of productivity is lost. And also it leads to untapped diseases, which will lead to comorbid diseases anyways. So what is snoring? Simple snoring is a complaint of 45% of adults. Nearly most of the people we know do complain of snoring, or if they deny it, we all know that they do snore, right? If any one of us have shared a room with any of them, we do know that they snore. So snoring is a cosmetic byproduct of obstructive sleep apnea. Is it a symptom? Yes, it is a symptom. But is that the only problem that we have? No. There are further, even graver problems which I will go into. But snoring should raise your eyes and your hackles, and you should, try and find out, why is the person snoring. So there have been friends of mine who have been asking. So there was one night, and a friend of mine, a girl friend of mine, and she said, I think I'm snoring. I think I need a device. So every problem has two faces to it, right? So do not jump into the other side and say that, I have a problem. If you have had a hard day at work, if you're really worked up, if it's been a really long day, and if you've been snoring once in a while or maybe once a week, it's not something that you should be alarmed about. If it is happening 3 to 4 times or more than 4 times in a week, it's something that is going to hamper it. But there's an age-old practice in our Indian custom. They say that if the person has eaten well and if he is lying down and he is snoring, that means man trupte and he is being very happy. But actually that is not the case. Those things need to be tapped into and those things need to be understood. What are the other predisposing factors? Obesity is there. So if you find the person who is obviously morbidly obese or on the verge of obesity, basically if you have higher cholesterol deposition around your neck, understand that it's actually going to cause you difficulty in breathing because the cholesterol is going to try and compress your neck. If it's going to compress your neck, you are going to have friction when breathing and that is going to cause a problem. Secondly, if you have abnormalities in the oropharyngeal region, that means if you have anatomic obstructions, that means if the lateral pharyngeal throat form is collapsed, if you have a longish uvula, if you have crowding in that area, tonsils, adenoids, any of those problems which are there, that is what I mean by anatomic problems. Then you have alcohol, which decreases tone in the muscles. Smoking is a high risk for OSA, and also aging, because generally with age you do notice a decrease in tone of muscles. Again, at this point I want to say that there's a patient of mine who said that, okay, because I explained to him, like your tone of muscles is not very good and otherwise you're okay. He was not obese, but he had an obstructive sleep apnea. Like, okay, how do I increase the tone of my muscles? So it's not like your other muscles. You can't go to the gym and work out throat muscles. Those are internal muscles. There aren't any exercises which you can do. There are studies which say that playing a musical instrument called as a didgeridoo, which is I think available in Australia. So those are the instruments which you can use and they are going to help you train your vocal cords and your inner throat muscles. But apart from that, there is no gym kind of exercise, Otherwise you say like, okay, tone badana, let's go hit the gym. That doesn't work over here. It's not so simple. You're just born with it or not. It's unfortunate. So what is it that you are looking for when you're looking for signs and symptoms of sleep apnea? Frequent urination, daytime sleepiness, loud snoring of course, recent weight gain, difficulty to lose weight recently, impaired memory, moodiness, gasping, choking sounds, night sweats and morning headaches. Now the morning headaches and I guess only the morning headaches also will go hand in hand with the TMD problem along with it. But we'll come to that later. But if we are trying to understand, if you have more than 4 of these symptoms, you are definitely a candidate who possibly has sleep apnea. So when we're looking at history, what are we looking at? What do we need to know and what is it that we're looking at? Whether the patient has witnessed apnea, whether there's history of snoring, whether there's excessive daytime sleepiness. What I mean by excessive daytime sleepiness, there's a questionnaire I have in my clinic. So it says that if you're sitting outside in the waiting room, if I'm doing another patient before I'm going to be able to look at you, what is the chance of you feeling sleepy? So it does not mean that I'm walking around and I don't feel sleepy, but at a point in time, if I've asked you to stop walking and I've asked you to sit in one place, what are the chances of you feeling sleepy? You'll be surprised at how many of us even right now will say that possibly it's possible maybe I'll feel sleepy. Everyone wakes up in the morning, you have a long day before you, whenever you get a chance to sit down, after lunch you're sitting down where you don't have to walk and you have like 10 minutes to sit. There's a very high likelihood you will doze off or you will feel sleepy. But like I said, we have been brought up so that we are supposed to work like the sun. Till the sun doesn't go down, actually our efficiency should be at our peak maximum. So we should be able to function throughout this time. So if we are getting these sleepiness episodes, it's something that we need to think about. Restlessness, unrefreshed sleep, excessive nocturia, difficulty in concentration, all of this we've spoken about. Whenever we say excessive nocturia, or if the patient does not have diabetes, there is a likelihood that the patient, if he's having an apneic episode or he has obstructive sleep apnea, that means there is a stoppage of breathing. The brain sends a signal to your body that, hello, this fellow cannot breathe, you need to wake up. And how is it that you wake up? You end up turning on your side, or you end up feeling thirsty, or you end up wanting to go to the loo. It's your brain giving a signal that you need to get out of bed, move a little bit and then go back into bed. So if a patient says that I need to wake up 3 to 4 times at night because I need to visit the bathroom or I feel thirsty, you'll be surprised at the number of times he needs to wake up after giving the device or after being treated for sleep apnea. It possibly comes down to 0. Because imagine a baby, when you have a newborn, if you say that his nappy is clean and his tummy is full, he can sleep for the whole 8 hours. He does not need to wake up, right? So similarly, we are also brought up that our stomach should be clean because we do go to the bathroom before we go to bed. So ideally, things should not function because everything is functioning at a low level. Remember the sleep pattern that I told you, everything works at a low level. So the entire body system does not stop, but it is working, but at a low level. That means we are not generating enough body fluids, we are not generating enough activity, and we need to be able to function in such a way that when we wake up in the morning, we can continue all the activity. So it's crazy. Once you'll come to this and you will notice how many changes you will be seeing. In physical examination, this is what we already spoke about. If you're obese, large neck, retrognathia, micrognathia, if you have a crowded airway, that means if your jaw is collapsed or is compressed, if you have a high arched palate, enlarged tonsils, nasal deformity or septal deviation. Over here for this, we being dentists, we do look at the head and neck region. So we are adept at looking at the nose also, but many times we don't end up looking at the nose. We don't end up even looking at the symmetry of the face. We don't end up looking at the posture of the patient when he's walking in. So it's important to try and notice all of these. In prosthetics, we do get trained to try and see all of these things a little bit further. But whenever we're checking a patient also, first is move below, but first assess his face, assess his demeanor, assess his motivation to get treatment done. So similarly, even with the nose, we can look at the nose, you will be able to notice septal deviations. If in any doubt, of course, refer to an ENT. And different comorbid conditions which we have spoken about. Why smoking? Now what happens with smoking is there's an inflammation and increased mucus formation which happens with smoking. Also there is a disrupted circadian rhythm and a sleep cycle. So your sleep cycle gets disrupted, and also you have damaged upper airway muscles because of the anaerobic flow. Because of all of these reasons also, smoking is not a great idea. And if you have a patient who has obstructive sleep apnea, first thing try and explain to him that if you can tone it down, it will be fabulous. This also, I think we've gone in detail, this is just a review. So it will affect your cognitive function, immune system, appetite, metabolism, skin, mood changes, heart health, and has an increase of cancer where your brain and your heart are not in sync. And sleep-related breathing disorders, those are the syndromes: central sleep apnea, hypopnea syndrome, and obstructive sleep apnea, hypopnea syndrome, and hypoventilation syndrome. So what exactly is parasomnia? It is unusual and undesirable physical events or experiences that disrupt your sleep. So we have all these ghost stories, right, and all these horror movies we watch. So many times those people, the activities that they do in those possibly could be any of the non-REM or the REM parasomnia disorders. Because if you go through it, something like sleepwalking, confusion, arousal, sleep eating, all of them are non-REM sleep disorders. That means it's an unusual activity which is happening in your sleep. A REM sleep behavior could be a nightmare disorder, frequent sleep paralysis. Many of us may have noticed it, right? I had a dream and I felt that I was falling, but I couldn't move at all. I was really trying hard and I couldn't move. You know, I was jumping, but I couldn't move. So that's kind of a sleep paralysis. Now that does not mean that you had one episode, that means you need to ring your alarm bells and that means you need to run to consultant. No. All of these things can happen. Parasomnias are also to an extent normal till they become excessive. Exploding head syndrome, that means if you have really bad headache, sleep enuresis, sexomnia, hallucinations are some of the others. So what is central sleep apnea? I said that when your brain and your heart are not in sync. So imagine if you're having an obstructive episode, your brain usually tells your heart that you need to start pumping because this fellow can't breathe, so you need to start pumping harder. Imagine if those neural pathway is damaged. So your heart cannot send the signal across to your brain, and possibly the heart will keep on at a decreased function, and the obstructive apnea can go into a very morbid condition. So it happens because of a serious illness, usually the one that affects your lower brain stem, which controls breathing. So the neural pathway itself is affected, and the symptoms are not like snoring. Sometimes the symptoms they can have in cases of congestive heart failure, hypothyroid, Parkinson's, Alzheimer's, and different kind of stroke or injury. So this is a different kind of disorder. So whenever we do any kind of sleep studies, they will also tell us if we have a central apnea. Whenever you find symptoms of central apnea, you have to transfer the patient to a neurologist, because let the physicians know how to take care of it. Then this is not your piece of cake. Don't dip your hands into murky waters that you do not know about. Mild to moderate cases are where you are going to play and you are going to have a huge playing field. But if you know that things are going out of your hand, do not get into those cases. So what exactly happens when we sleep? when we are lying down, our tongue falls back. Because of gravity, all our muscles, tone is reduced. And your pathway, you usually are supposed to breathe through your nose. There are few of us who breathe through our mouth, but we being dentists, we do try and tell the patients, right, to keep your mouth closed and avoid mouth breathing. So this is what is supposed to happen. So nasal breathing has a huge amount of benefits also, and that is how your pathway will remain open. This is what happens normally. What happens when you have obstructive sleep apnea? Can you see the tongue has fallen back further? Alright, so when your tongue has fallen back further, possibly your nose may not be fully patent. Imagine the patient may have a septal deviation, it may have congestion, may have some kind of a cold or inflammation. When that happens, you end up breathing from your mouth also. So the mouth is staying open over here and the airflow is getting obstructed over there. So there is a wavy pattern which is forming. That means there is a constriction of the airflow over there. When that happens, that means there is friction in the pathway. When you have friction, the cosmetic effect of friction, what we hear is snoring. So when you see snoring, what is happening in your body is you are having constricted airway. That means you can imagine you're having actual friction in your throat. So what you do, many times people say, I can sit up and I can go to sleep. You know, many of them can sit in a reclined chair and they can fall to sleep. But whenever I'm lying down, I can't breathe. This is very common symptom. You will hear this many times. I cannot breathe when I lie down. What is happening when they're lying down is your tongue is too large for your mouth, or it's falling back too much. The patency of the airway is not enough, and that's why you're having difficulty in breathing. Automatically, when you're in a reclined position, your airway is staying a little more patent and you can breathe better. So what we need to see is, do they have nasal blockage? Do they have upper respiratory problems like adenoids, tonsils, soft palate anatomy? For this, if you can visualize, that's great. If you cannot, refer to an ENT who will be able to tell you what to look at. And lower pharyngeal narrowing, that means look at the base of the tongue and look at the size of the tongue. So in physical exam, this is what we want to understand, whether the patient has nasal obstruction, oropharyngeal obstruction, hypopharyngeal obstruction, whether there is a microglossia. Look at the size and the space for the tongue. Look at the amount of crowding in the space. Look at the arch form of the palate. So these things, when you look at, when you start looking, so they always say, right, if you know what to look for, you will be more intelligent. So now we all are very smart when we want to detect caries. We can see a grayish hue and we know, bus X-ray vision hai hamare paas, and we can say, I know there is a cavity over there. So similarly, with OSA people, once you start looking, once you start knowing where to look at, you'll be able to find out these cases a lot more. As soon as you see crowding, as soon as you see a narrow mandible, as soon as you see a very high arch palate, as soon as you see some scalloping on the tongue, your eyes and ears are going to be like, this is what is important, this is what it could be. Now I need to look at this. Let's ask the patient a few questions. It'll be very interesting, try it out. So these are very common things in which we do notice every single day when we ask the patient to open his mouth. So you'll be able to notice these things. And obviously look at the neck circumference and general body composition of what the patient is like. So when I say a patient needs to be obese to have sleep apnea, that does not mean a lean mass person or a person who is looking extremely fit and who is lean may not have obstructive apnea. Can anyone tell me the reason for this? I've given you quite a few examples of why you may have obstructive sleep apnea. Let's see if anyone is awake. Think about it. You can think out loud. It's okay. I told you I was not a great student, so I'm not going to judge you. What happens when you are obese, right? Tell me, what do you see exactly? So you see your throat, and when you see your throat, you see cholesterol deposition around your neck. What else is happening in your neck? You may not have any other bodily fat, but what else? What are the structures inside your neck? Adenoids, tonsils, exactly. So the anatomy, that means the basic anatomy. You can have lateral pharyngeal narrowing, you can have the obstructive events, you can have a uvula. So any of the normal anatomical features may be enhanced or may be, enlarged in certain individuals who may not have obesity, who may have narrower faces. So many times actually the faces look leaner. So many young women who come with very lean faces and they may actually have obstructive sleep apnea. So that does not mean tell them that you need to start exercising. No, they need to get a surgical consult. You need to send them to an ENT and get those tissues in the back of the throat corrected so that you are going to open up the air. When you understand airway, you have to understand what is it that I'm going to do to make you be able to breathe better. You need a larger volume of air for you to breathe better, actual passage of oxygen. For that also you need larger amount of space for your tongue, and you need your teeth to be in a proper alignment so that your tongue will have space. Otherwise it's going to try and push and or fall back. Either of those. So try and provide the most ideal circumstances in the mouth and also in your airway. So what are the consequences of untreated OSA? You can have cardiovascular events, you can have CNS events, you can have cognitive impairment, and these are some meta-analysis. This is what I wanted to talk to you about. So whenever you all have research projects, right? So you all can have a library dissertation or 2 short-term projects, which I heard recently. So when you're doing that, when you are gathering information, there's one thing which I got an advice on, and I think it's a really good advice. Instead of going for a single case study or something which is sounding very cool, like at the end of the journal you have a 1 case paper in which the person is trying to do on 1 case something different, an innovative approach. Instead of basing your facts, if you want to make a statement, instead of basing your facts on that one approach, it's always better to go in for a systematic review or a meta-analysis. What do those kind of papers do? They are taking evidence from all the documentation or all the data that has been there throughout, and they're analyzing that information and giving you a conclusion, which you can very confidently state that OSA more than 15 was associated with higher incidence of stroke. Am I saying this through my nose? No, because this is from meta-analysis. That means there are hundreds of reviewed papers. They have all studied on the same. They've come to the similar conclusion, and there's one person who studied those papers and has come down to this conclusion. So it's always important when you are trying to do your research projects to go in for systematic reviews or meta-analysis kind of reviews to base your data from, or to base your, how do you say it? You want to give a baseline to your project, or you want to understand, this is what this fellow says, or this is what this fellow said. Instead of that, you say it as a systemic analysis. It will have much more weightage and you will not be wrong. Also, it has endocrine, perioperative complications. This is what I spoke to you about, right? If you go to a bariatric center, if you want to intubate the patient, imagine there's a lot of cholesterol, there is a lot of thickening, there is no way that I can push in a tube inside. So it has exaggerated respiratory depression from anesthetics and analgesics. So you're already pumping the patient with a decrease in tone medication. So in such cases, it's important to consult with your anesthesiologist before you go in for the complications, before you can tackle the surgery, basically. So whenever we try and tell the patient, अब ये सब आप समझ गए हो, what are the tools which I'm going to give you so that you will be able to understand what you need to do. So we have tools also in sleep. We have something called as sleep tests. This is what is called as a polysomnography. So it can be an overnight polysomnography, it can be a home-based sleep test, it could be multiple, it could be a split night sleep test, it could be a multiple night sleep test. All of them basically it requires to detect the frequency of apneic and hypopneic episodes at night. So like I said, I cannot understand what Dr. Kamal is doing at night. She seems to be sleeping okay, but what is happening to her oxygen saturation level? What is happening to her heart rate? I do not have any kind of superhuman powers that I will know, but we have superhuman technology which you can attach. So you have ECG leads, you can have wrist held devices, and you can get all of this information. All of these tests are very easily available now. There is a technician whom you can send to the patient's home, they'll set it up for you and you get a generated report the next day morning. So you yourself do not have to go, the technician does not have to sit there by the patient's side, so it's not at all awkward. The patient can do the study in his or her home. If the symptoms are more, or if after a home sleep test you feel that you need more information, you have to go in for a hospital-based sleep test. Over there you will have your own room, you will have a hospital bed, there is a kind of a screen, and there is a technician who is sitting away from you. So you are sleeping alone in that room, but the technician is kind of monitoring what is happening to you, because the number of leads in that polysomnography, that means your sleep test, are much more, maybe 13 channel, 14 channel or more. So what we have to understand from the sleep test is what is the apnea-hypopnea index, or it is called as the AHI, the average number of disordered breathing events per hour. That means how many microseconds or nanoseconds amount of time did you not breathe, or did you not breathe efficiently, is a better way of saying it. So OSA syndrome is defined as an AHI of 5 or greater with associated symptoms. So this is what we already spoke about. You also have phone apps nowadays. So many of the patients say that, my phone says I have slept enough. Why are you saying it is not enough? So like the phone, like your heart rate monitor in your watch, all of them are guidelines. They are not going to do away with your basic gadgetry, right? Your age-old gadgetry. Just because they're digital, that does not mean they're extremely accurate. So those will work like a guideline. I'm not saying they're wrong. They put you in a range, but that is not exactly accurate. So once you say the phone app is saying, maybe I've not slept well, maybe I am. You tell the patient, that's great. We'll try our phone also, and why don't we do a home sleep test also along with it? So instead of arguing with the patient, and then the patient themselves can see the difference, Those finer nuances are not caught with your phone. The phone is not on your chest to understand your oxygen saturation level. It does not have a wrist held monitor. It does not have a pulse ox saturation device. So it can't be as accurate. So these are a few definitions. I'm not going to go in detail. This is just for information. So when you're reading a sleep report, you come across all of these terms. You just need to know what is important. RDI is something which is the most commonly used term now. RDI and AHI go simultaneously, but AHI is an apnea-hypopnea index and RDI is similar, respiratory distress index, because it has something which is called as RERAs, respiratory effort-related arousals. Those are also included. That means small disordered breathing events may not be apnea or may not be hypopnea. So they cannot be, you cannot go into that category of saying that it is actually an apneic episode, but it could be a smaller episode which are called as RERAs. So this RDI is going to be that. This is what a regular sleep test report looks like. Over here, what we want to see is, can you see that in red or orange? 30, yeah, 20.3, right? 20, yeah. I'm really bad, I can't see it yet. So, so when you find the number, you want to understand what is the respiratory index, or your AHI, or your RDI. All of them have similar information. That is where you'll understand. So when you have mild to moderate, that means more than 15 becomes your severe. When you are, I think, between 5 to 10, you become moderate. And when you are more than that, you are severe. So you want to understand where the patient lies. This is what your overall report will look like. It gives you the number of hours you've slept, the amount of sleep latency, what time are you going to bed, were you on the left side, were you on the right side. It gives you too much of, according to use this information. What is important is to understand what is the oxygen saturation. That means DSAT kitna ho aapka. If you are ideally supposed to be between 95 to 100, what happens to you in the middle of the night? Do you go down to 80? Do you go down to 79? Those are red flags which you should watch out. And also whether your apneic index is increasing. So this is what is a kind of a test result where the patient has started using a CPAP machine. And that's why his level has come down to nearly 2. This is our ideal standard. We want to try and get our values below 5. That means you have success in treatment. You can also have this kind of report in which you are also getting a graph. You also get an average and a max AHI interpretation. According to this, it just helps you gauge and put your patient into one of these categories. So how do we treat these kind of cases? Your gold standard is going to be a CPAP. That means a continuous positive airway pressure machine. This is what the machine looks like. It's got a mask. There are many interfaces to this machine. It can be a full face mask, it can be a head face mask, it can be a nasal cannula. There are multiple varieties of masks. But what basically this mask does is it gives you a constant stream of air when you are in your sleep. So imagine you are going Pune, Bombay, when you're on the expressway. Let's say you're on the old expressway, and when you are going on a casual trip, you want to put your head out of the window and you want to breathe in, right? When you're breathing in, you open up your mouth. Imagine the force of air that's going inside your mouth. Imagine sleeping throughout the night with that force of air. That is what a CPAP is doing. When you have this forceful air which is going inside, obviously your airway is going to be kept open. Imagine your airway is like a hose pipe. Garden mein aap pani lagate ho na, the same pipe. If there's no water in it, it goes flat, it goes chapak. And when you turn on the water, automatically it becomes larger, the patency increases and the water will flow through. So the CPAP is going to act like that water or act like that air. It is going to help you breathe better. It keeps your collapsed airways open. A BiPAP is similar to this. It has an inhalation and an exhalation pressure. So these are easier for patients to deal with, because imagine going at a very high speed throughout the night, it's very difficult to breathe. imagine it's going to feel extremely tough to breathe. So if there is a different kind of pressure for inhalation and different pressure for exhaling, it's usually better tolerated by the patients. They can be different types of BiPAPs also. So this is what the CPAP is going to do to you. You remember the normal anatomy diagram and you remember the obstructive anatomy diagram. This is what happens with the CPAP. So what this is doing is giving you the green arrow is the forceful oxygen that is going inside your air. Now with CPAP, the problem has arisen that it requires a humidifier. And with COVID, we know how bad humidifiers can be, right? So you have all of these cases with mucormycosis. So everyone's being very scared of this nowadays. But this eventually is the gold standard. Nowadays, with better humidifiers, or you can manage to keep them clean. Earlier, it was like, kuch hai, machine chalu hai. Now people are more vigilant. People who are using CPAPs, they maintain them, they clean them better. But this is what it does. It keeps your patency open and you can breathe better. Now, there are patients who may not be able to deal with this. If I tell you that, okay, you have sleep apnea, you're in the severe category, I want you to start using the CPAP machine. This is your machine, chalo, go chalo. The patient will say, okay, I've been diagnosed, I've been treated, let's start using it. It's not always easy to go to sleep with a mask on your face. First of all, it may not be okay with your spouse or your partner who's next to you. Secondly, it may not be okay if you're traveling. Thirdly, it may not be okay if you're going on a vacation with your friends. You don't want to carry this ugly looking device. And thirdly, it's just uncomfortable. You may feel suffocated with wearing it. So that is where we come in, where we can give you dental appliances to be able to do that. So after we've finished all of this, we come to questionnaire. So these are questionnaires which are available online also. There are different questionnaires. There is a Epworth Sleepiness Scale, there is a Stop-Bang questionnaire, there is a birthday questionnaire. So you have to understand and ask the patients, do you snore? Do you feel tired? Have anyone told you that you feel sleepy? If your score is anywhere more than 5, that means there's a chance of you being in a category that you need to be diagnosed or you need to be at least checked further. So these are the kind of questionnaires that can be used in the data screening tools. So what is it that we can do when I come from a sleep medicine point of view? So being a dental sleep specialist is one part of the problem, but a dental sleep community is a large community. We all need hand-holding, right? So we prosthodontists, we never say that I can do everything. There's someone who's good at oral appliances, there's someone who's good at implants, there's someone who's good at crowded bridge, there's someone who's really good at something else. So if we come across a patient, we have to understand that how do we treat the patient? The patient is supposed to be our guest. Patient needs to be dealt with first. That's why it requires a multidisciplinary approach. You need a physician to diagnose this issue. You need an ENT to advise on surgical protocol, because if you cannot see what is there in the back of the nose and the back of the throat, you need the ENT. Imagine the lean girl I told you about who has the anatomic obstruction. So she is going to go to the ENT. You are in no way going to help her. Apart from that, the sleep dentist, if you have non-invasive ways in which you want to help the patient, that is where you will come in. You may need a psychologist because patient may have a depression problem, the patient may have a stress, anxiety problem, may need other counseling for that. A lifestyle management advisor, that means either a nutritionist, exercise coordinator, any of those, because nowadays you don't call them clinicians, you call them lifestyle advisors. So every time we come across a fad diet never works, you always say that it has to be part of your lifestyle. Don't go in for something which is going to be transient, go in for something that's going to be long term and which you can incorporate daily. So a lifestyle management advisor will come in. A bariatric surgery team, if the patient is obviously obese, you are going to require this kind of help. A pediatrician or pediatric ENT, and will also need support staff to explain to the patient what is happening. So this is how usually I have my workflow. I do initial consultations, I do some screening, I follow up with different types of sleep studies. Then I ask the patient to start using some kind of dilators. If there is an obvious problem in the base of the nose or a nasal septal deviation, many times the dilator, the nasal strips can help improve that. Then you make impressions, deliver customized sleep devices. You also need to follow up. Over here I've written follow up for 3 months. I recommend doing a follow up every month because the patients may need a progression of the device. I'm going to talk to you about what is the device and how do we do that. And you may need a corrective treatment plan, which can be prosthetically, orthodontically or surgically driven. These are the kind of nasal appliances which you can prescribe. They are all available online. You have products which are there. Any kind of nasal dilators. What is it going to do? Imagine I want you to keep your nose open and keep your lips closed and nose open. So if you can breathe fine with your lips closed, that means your nose is fine. If you're having difficulty in breathing, that means possibly there's a deviation or there is some kind of problem in your nose. It could be an anatomic problem, it could be a mucus problem, it could be chronic infection, it could be any of those things. But to be able to keep your nose open, you may need some help. That means you want to put a stent inside your nose so that you can keep that pathway open so you can breathe. So these are simple devices, these are use and throw devices, they're great, they work well, and they're as trial devices. So once the patient starts using them, they know that it's making a difference. And if this is really helping, then you tell the patient possibly you may need an ENT consult and get that thing corrected. Jo deviation hai, whatever the problem is, get it corrected. So I'm going to show you in short how do I treat a patient. You take basic pictures, you can see a little crowding over there, you see a very high arch form, you make regular impressions. This is an inter-occlusal sleeve device plate. That means you need to take the bite of the patient in a protrusal manner along with a raised vertical. Once you get this record, you send it all to the lab. We have a lab in Pune, so Katara lab does all of these devices for you. And this is what the sleeve device looks like. So basically they are kind of hard acrylic upper and lower guards, and they are connected together by a changeable blue clip. This blue clip is actually going to hold your jaw position forward. This is what it will look like in the patient's mouth. So you will have an opening in between and the patient will be able to close over. So there's a slight increase in vertical and the jaw is held a little forward. This is what the device is going to do. When you start wearing the device, it is going to pull your lower jaw forward, it will open up the airway, so the obstruction is there in the back of the throat. It also pulls along with it the base of the tongue. That means all our problems are getting vanished. That's why I said if you are moderate to medium cases, that is where the device is going to be of much help. If you are in a severe case, that device only has a certain play. I cannot take you much further, it's going to cause a TMD problem. So only till an extent I can take you forward. That is why your moderate cases work best for your advancement devices. So who are the ideal candidates for the advancement device? When you have a mild to moderate AHI, that means between 5 to 20, when you have obstruction in the hypopharynx in the upper part, when the patients who cannot tolerate a CPAP, of course, patients who have a very large tongue size, patients who have compromised airway space in spite of going ahead with an adenoidectomy or a tonsillectomy, patients who do not want to offer surgery or reduce the pressure of CPAP. Now this is important because sometimes the patient can use CPAP but the pressures are very high. They cannot tolerate that pressure. They're saying I'm okay with the mask but your pressure is very high. So you have a combined treatment. That means you give them a device and you start off with the CPAP so that they can breathe better. And also for children with ADHD. So there is like multiple studies. So there was a pediatric sleep conference. I know you have quite a few, you have pediatric PGs right over here. So it's very important. I want you to know this. So pediatric sleep is a huge problem, and patients who have ADHD, patients who have attention deficit problems, it's very likely they're not getting enough sleep. And there are studies which say that if you get an adenoidectomy or tonsillectomy, patients are actually eating better and they're sleeping better, and suddenly they're much more efficient in what they do. It's such a simple way of solving the problem. But there are many studies. I think you should look up into this problem because it's going to be a very interesting study topic for you all, or at least a very good reading topic for sure. I don't know how many of y'all read, apart from study books, of course. Y'all are meant to read study books. I'm an avid reader, so I usually end up reading. Obviously, there's some kind of a intellectual conversation that needs to go on with your brains. You do read a little bit study, but always on the side I like to read something much lighter. But yeah, so if you get a chance, try and look up that topic. There are a few contraindications for mandibular appliances where you have absence of posterior teeth. Imagine I want to be able to hook the device into certain teeth, right? If you don't have enough teeth in the back, you're not going to get enough protection for your device. Untreated periodontal disease, because there are certain changes which can occur because you're actually causing force. So if you already have mobility of the teeth, they are not great candidates. Or you get that periodontal condition treated and then if you have an active TMJ problem, this is not an absolute contraindication, this is relative contraindication, because I'm going to come to you and show you studies in which whether you have a TMJ travel on their own, right? They want to do all these girl vacation trips, and they're very discreetly they say, no, actually, I think I snore. I don't think so. It's March, but I think I should get treated. I said, has anyone told you? She's like, no, I want to share a room with my friend. I don't want her to suffer. So see, there it all comes out. So that's when they start thinking about it, and then they want to get some kind of devices so that they can share a room and they can travel peacefully. Also, you can have a possibility in reduction of blood pressure. So there is a patient of mine. She is, unfortunately, not added any pictures of her. If you see her, she looks stunning. She must be 60 by now, and she has 2 fully grown kids. She plays soccer, and she came to me and she says that I have a problem and I am already taking medication for blood pressure. So she's been my patient for the longest time, and she is very lucrative for me. I keep telling her, I'm like, मेरा धंधा बढ़ाना है तो ऐसे मत बढ़ाओ. You send me patients, because she has a doggy in her house, and her doggy ends up eating her sleep devices all the time. So I've made up to 4 or 5 devices for her. Because she said, no, I cannot live without it. I said, why don't you just take care of it or put it in a dabba, or you know. But it's funny. She is the one who has actually stopped medication for her blood pressure. She was diagnosed with high blood pressure. She was on a mild range, and she has started taking medication for the same. But after getting diagnosed with sleep apnea, after starting using the device, she has completely stopped medication. So it's lovely. It's a whole feeling. No, thank you. I'll have some water. We're trying to get through to dentists, we're trying to get through to physicians who need to know that there are dentists who are here to be able to tackle the problem for you, deal with it. There's a lack of education in the field, that is why there is no confidence. You know, many people say that, हमने सुना है, but I don't know how to deal with it, I don't know what to do about it. It's a lovely, because there is a course coming up, there is a lab in the South India, I'll tell you where, I have it on my phone. They're coming with a course which is coming up in March. They're starting a sleep course for dentists, for undergrads, graduates, postgrads, for all of them. So there will be, it's a continuing education kind of course. So if anyone is interested, please let me know. I'll send you the details of that course. So you want to start off, it's a great one to start from somewhere, right? Because every time you want to try do something different, I always say, get proper education, get taught by proper people, get taught by the books, then you go and observe for the person who are doing it, and then you start with your own patients. It's not okay to jump into clinical practice immediately. That also gives you confidence in managing complications. Once you've studied enough, once you've read enough, if a patient says that मुझे ये problem हो गया, now what do I do? He's going to come and catch you. You are very good at talking to him before, and you say, oh, I'm going to do this, I'm going to do that, and now there's a problem, there's a pain in the TFT. What are you going to do about it? So once you read enough, you will know how to manage the complications also. And we always have this fear of interdisciplinary practice. We say that if I send it to the ENT, वो patient का problem चला जाएगा और मेरा sleep का patient चला जाएगा. You know, that does not happen. It's always a give and take. You will do a little bit, and the ENT will always send you 10 more patients, because he knows that you are dealing in this topic, and one person may get treated, but there are other 10 people who may come to him who he cannot treat, right? So there's always, it's always cohesive. Once you tell a prosthodontist sends a person to an endodontist, you will always know that if not that single case, another case will come back to you. So it's always a give and take, and I think we should always have pride in our profession and try and inculcate and encourage everyone. So there are different people who can deal with this. What are they going to do? They are going to check you on different interfaces. They're going to check your appliances. They're going to check what is going to happen in your bone level, whether surgical construction can happen. Over here, there's one which is lacking is the orthodontist. There should have been another column over there for ortho. Because oral surgery and orthodontist is another way to go about it. If we cannot move the teeth physically, we can go ahead and do them orthognatically or orthodontically. So get them in the right position after doing that. So this is an interesting paper in which it says, what do patients prefer. They say that go ahead and do this study. Go ask your patients whether you will use a device or whether you will use a CPAP. And most of them you will know the answer. Everyone would prefer to go in for a dental treatment because it's removable, it's non-invasive, it's cheaper and it's simpler. So the more you read, the more fun stuff you come across. Sleep and bruxism are very intermingled topics. So bruxism, we all know, is a bane of our existence. It can ruin your restorations, it can ruin excellent work which is done by you. It needs to be thought of, it needs to be planned, and you need to be able to assess it before you start with the treatment. This is one kind of device which I have come up with for bruxism. It's like a twin block appliance. I've also given some kind of loop. So this is not this is an old device. So this must be at least 5 or 6 years old. It's made of our regular acrylic resin. It was a trial case, so I'm seeing how the patient is performing. He's doing extremely well. So he was grinding through his regular sada plastic device which I made for him. He was grinding through it and he was breaking off those clips. Because after all, it's a very delicate piece of equipment. You know, imagine a high-end bruxer. He's a large 60-year-old man. He's a runner. He's grinding his teeth like anything. He was chipping away those things like anything. So we made him a regular acrylic plate for the upper and the lower, and there's a twin block kind of appliance on the side. So there is a way in which the mandible is pushed forward. And I also gave him those hooks because he's saying otherwise my jaw is staying open. So simple out of the thinking box can help you think better. I'm sure if you all also put your mind to it, you will come up with more different ideas. There are, I think, more than 125 appliances which are available for dental sleep apnea. Most of them are available, different designs are available in the USA. I thought of it when I came back and I said, I'm going to do state-of-the-art practice and I'm going to do only very fancy appliances. When you speak to the dealers and when you understand, they say, we'll make it for you. Send us your impressions and we will deliver it. Like, how much will it cost? It's $100. That's all. And that is apart from the shipping, that is apart from your cost. This is only the lab cost. So this is not feasible in the kind of setup at least I work in. And it's silly for me to even tell the patients that, this is how much you need to pay. And of course, in the end you're saying, I'm hoping this works. You're never going to guarantee to the patient because you are sure that it is going to reduce the symptoms, but it's not going to completely let go of the symptoms. So you're not doing a surgery, right? So the cost is unwarranted. So you need to come to think of different ways in which you can work with your own lab, which you can make your own devices to be able to get the kind of end result that you want. Again, TMD and sleep are again interlaced. There are cases which say that if you have an active TMD, do not touch the patient, but there are cases which say that if there is an active TMD problem, it will not get exacerbated. The oral appliance will not cause complications. So you need to understand the egg and the chicken story, which comes first, and you need to use your conscience to be able to decide how to go ahead. So sometimes when you have a TMD problem, it's best to go in with a simple anterior wide platform case, and that itself is going to increase the vertical and the sleep problem may actually disappear. So do simple things first, don't forget a basic dentistry. Try your simple things first. There's a high likelihood things may just fall and we may just be happier. Now geriatrics and sleep, we know that sleep pattern changes as we age. It's going to keep changing. When we were younger and as we age, there's going to be change in our REM cycles. Along with it, what is it that we need to know? That we need to understand that there needs to be a routine. As we grow older, many times regular lifestyle keeps changing. So you don't have a set routine. You end up taking long naps. You end up munching in the middle of the day. You don't have a fixed routine. So try and tell all the elderly people in your home and in your patient scenario that you need to stick to routine. You need to do a little bit of exercise. You need to take a little walk. You need to avoid caffeine at least 6 hours before you go to bed. So few things which are common sense you need to understand, and that is itself going to play a long role. How do we treat the elderly? CPAP again becomes a treatment of choice. Now again, many of them could be edentulous, maybe partially edentulous. So if CPAP cannot work, you think of oral devices. There's something called as positional therapy. That means if you want to ask the patient to be able to breathe better, you can ask the patient to sleep on one side or the other side so they can breathe better, because if you are on the side, the tongue pressure gets relieved. A little amount of weight loss is important, surgical management and ENT correction if required. The worst case is tracheostomy. If the patient can't breathe at all, go ahead with tracheostomy. Some of the symptoms may resemble dementia. So don't confuse the symptoms of OSA with dementia. So this was a lot of information overload. Let's go to some cases. I'll quickly show you what all we can do. Tell me your treatment plan for this case so I can have some water. Now I have not put on the CBCT, but according to what you see, what will you do with this case? Okay, short and time, I'm going to go ahead. This is what it looked like. Multiple decayed teeth. We went ahead and did a old lower arch extraction, placed in a few implants. Now what I went wrong over here is, if we have a patient with a sleep disorder and if he can't breathe, I want to compensate that, and he's a 65-year-old male. He looks very fit and healthy, so he's actually doing very well, but he comes with his son, and son is complaining more than the father, because now you know how sons are. Son is saying that no, ye ho raha hai, wo ho raha hai. I'm like, let uncle speak for himself. Uncle is very chill, he's not saying anything, but son has a lot of complaints. I should increase the number of implants, maybe in the lower arch, added a few more in the back. When you think that the patient may have a bruxism along with a sleep disorder, always increase the number of implants that you have. You go in for your open trials, you do a CAD imaging, and after that I also placed in three implants on the posteriors in the upper also. So we've done a full mark. We've got his correction into a more class 1 from where he was in a severe deep bite and a class 2 relationship. We've got him in further, and now he's very happy with whatever he has. So he's breathing better, he's sleeping better. Did he come to me with only sleep? No, he actually came to me for full mouth rehab also. But when you open your eyes and when you see, you will notice he has all of these episodes. He can't sleep well, he has nocturia, he's got trouble digestion, he's got so many issues. Once you get everything in place, he is going to be able to be a completely new man. There's another case, I should put the pre-op pictures first. So, I don't know if you can see this. The lower posteriors are actually completely inverted. They're completely in this angle. When you should have had them vertically, they're completely in this angle. So this is an orthodontic case which has been referred to me by an orthodontist. Mandibular expansion try kiya unhone, but he said this is all I can do. So try to widen up the arch, not possible. We went ahead and did a mock-up, increased the vertical. So from the angulation of posterior, we've gone up and opened up so that the tongue can have more space, and given him crowns, given her crowns in a more wider area. So the lateral platform was increased. So she was over here, and this is unfortunately for her, this is the third time she's going ahead with the full mouth rehab. So this is the third time she's taking out her crowns and doing them again. So I've been very skeptical about this case, and we have kept her on temporary. She's still on temporaries and she's doing fine. I've been nursing her for 1.5 years now, and I've not yet completed the case. We're still working with the temporaries. You need to be very careful. So look at the change in the vertical direction and look at the change in the bite. From that class 2, I've gone nearly edge to edge. So when you open up the bite, when you increase the vertical, you're creating more space. You're giving the tongue more space, and that is going to help them better. And she also had a chronic, if you can see over here, chronic tongue bite problem. So she developed a cancerous lesion over there. Then there was a flat tongue. So she's been through what difference. Make sure you know what difference that you want to make. And we all know about this. Hopefully you come one day in life when you don't need to introduce yourself, and your work itself will speak for yourself. And in the meantime, it's one of my favorite quotes I would like to end on this. How can I help you? Do we have any questions? Has anyone been awake? I know all of you have been awake. I've been watching you. So tell me, did you understand what I spoke about? Have you got an idea about what is sleep? I hope I have, how do I say, widened your horizons to start thinking out of the box. There are different ways to look at a patient. Don't only look at his teeth and caries. Look at the entire picture. Look at his void size. Look at the crowding in the teeth. Look at the scalloping in the tongue. Understand what is happening to him. Look if he's coming in stooping. Look if he has dark circles. Talk to him. How are you sleeping? Are you okay? Do you have any stress in your life? What's happening in your family? Thode baad mein karo, you will understand so much more about the patient. It's very interesting and it's extremely fulfilling, but all of this requires a lot of talking, a lot of counseling. So make sure if you want to get into sleep medicine, you have a lot of patience to be able to do that. You need to give time to the patient and that's one of the most, I think, the costliest commodity that we have now, giving time to the patient. All of us want to, let's do it quick. How do I move the patient from the chair as fast as possible? But yeah, if you have any doubts, then I will share that upcoming course which is coming up with NAM. So if any of you all are interested, do let me know. Do you have any questions?
Madam, wonderful presentation. Let me tell you that. I just have one small suggestion because I have done a lot of surgeries for obstructive sleep apnea, and I have also a publication on clip and fill syndrome with obstructive sleep apnea.
Okay.
Now, talking of surgery, sometimes what we have seen that even a small surgery like a genioplasty for a patient with microgenia, that goes a long way in correction of this syndrome. Yeah, so instead of pulling forward the entire jaw, what we do is that we do a genioplasty, pull the chin forward, and along with that the genioglossus and geniohyoid musculature. Yeah, and it pulls the tongue forward and opens up the posterior airway space. So we have done a lot of cases on that, and that has given us wonderful results.
Oh, that's fabulous.
Yes.
That's great to know.
Yeah.
I would like to take it done in a number of cases. What happens with me is I want to find the right person who I can refer the patient to.
Right.
So if that works and the patient has that confidence in the doctor, then I am safer enough in sending the patient over there.
Right.
So it will be lovely. I think that's fabulous. That's information.
You said about airway prosthodontist. Do we deviate from centric airway while doing that?
In a huge way. So the old norm is where you want to go furthermost, uppermost, rearmost, and all of those most in our definitions. So in airway prosthodontist, you're saying actually which is more efficient for your airway. Actually go more towards the class edge to edge. Not exactly, but which is more comfortable for the patient. So you don't have the patient go into an extreme centric. You have a modified centric or an open centric kind of place in which you are a little bit more forward, you're giving your airway more space. And I'm opening up the teeth, so you're actually making it a little wider. Your platforms become wider and you have more base. So for your tongue to fall flat, so the tongue doesn't go back forward. The tongue gets more space in this. It won't. So always, all of my therapies I always say on your temporary wait for 2 weeks and then if there is any change, you can always revert back to it. There's nothing wrong with it, but there's a chance the new will also work.
Thank you so much, ma'am, for such an